Well, in this week's Cardiology News, we have aspirin and PCI, also high sensitivity troponin now in atrial fibrillation, and long-term follow-up on estrogen therapy from the Women's Health Initiative. So to begin with, we have a very interesting quality improvement look at PCI patients who don't receive aspirin. Now, of course, we all say everyone should, but a very careful look at the Michigan hospitals and 65,000 patients over a 1.5 year period found that 7.1% didn't receive aspirin prior to PCI. These patients were more likely to have a prior GI bleed or present with cardiac arrest or cardiogenic shock. Makes some sense. When they did propensity matching, they found that those who didn't receive aspirin had a higher risk of death and stroke across multiple subgroups that would exclude shock, etc. And so I think a good reminder to us all that things so obvious as giving aspirin for PCI can sometimes get lost in the shuffle. I've seen it myself. And so that to try and build in double checks that aspirin has been given in PCI patients is useful. Next up, we have a look at high sensitivity troponin in a somewhat novel population, those with stable outpatient atrial fibrillation. This was a look within the ARISTOTLE trial at outpatients with atrial fibrillation, different anticoagulation strategies of warfarin or apixaban. And they found that high sensitivity troponin was a very useful risk stratifier. Now, interestingly, it was measurable in 99% of patients, hence it's very highly sensitive. But across the quartiles, it was associated with an increase in death, in stroke, and in major bleeding. And when added on top of the CHADS VAS score, improved the C statistics for all three of those endpoints. And so it looks like high sensitivity troponin may play an additional role in risk stratifying patients, both on the efficacy and safety side. And then a big follow-up study from the Women's Health Initiative with 13 years of total follow-up that looked at estrogen plus progesterone in women with an intact uterus or progesterone alone in those who had had a hysterectomy. The intervention phase in the trials were 5.5 and 7 years respectively, but now they have out to 13 years of follow-up. And interestingly, there was no big benefit that was seen during long-term follow-up, and really the mixed benefit-risk ratio was seen. For the combination of estrogen and progesterone, there was an increase in coronary heart disease events and in invasive breast cancer, about 20% higher risk during follow-up. There seemed to be also higher risks of stroke, pulmonary embolism, and other events. There were fewer hip fractures and lower risk of diabetes, and so a little bit of a mixed picture, but some major adverse side effects there. For the estrogen alone, there was non-significant improvement in cardiovascular events, a hazard ratio of 0.94, not statistically significant. No difference in invasive breast cancer, numerically fewer. But interestingly, when they looked at risk across the age stratum for the estrogen alone, there might have been a non-significant lower risk, but a higher risk in the older women. And so the authors note that these long-term follow-up data really note that there's no role as tested for chronic disease prevention of these regimens. But they do note that in younger women, it could be used for symptom management in those younger women where risks were not as apparent. And so for this week's Cardiology News, I'm Chris Cannon.